Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Welcome and the Honorable Prof.Dr. Salina Husain. Welcome to our Otolaryngologist Department, Diponegoro University, and the Honorable Dr. Anna Mailasari as Head of Otolaryngologist Diponegoro University, and Dr. Reri Haryati as a head of Dr. Reri Budiarti as a head of Otolaryngology Community Karyadi Hospital. I ought to start this lecture, and good morning to all participants. I would like to extend a warm welcome to this Diponegoro University Otolaryngology Center to all participants. It gives me a great pleasure to be anchored to this lecture, and I'm gratefully to be hosting this event. Before we begin, please make sure our phone cell on silent mode. We encourage to all participants to ask questions from this lecture, and please make sure we stay until the end of the lecture to get a holistic understanding in this topic. And I ought to start this lecture with sing a national Indonesian anthem. Please remain standing to all participants. To all participants, to please to come sit back again. And then we go forward to the opening speech from our beloved Dr. Anna Mailasari as a rhinologist consultant. Welcome, Dr. Anna. It's your time.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you for Prof. Salina for your willingness to share your experience and knowledge with us. And I also thank you for Dr. Reri and all the staff and also the alumni from the ENT and the ORL SNS Diponegoro University and all our beloved resident, Prof. Yes. Today we will have a lecture and maybe a case discussion in this section for this morning until this afternoon. And the lecture we will give from Prof. Salina. We would like to uh, uh, learn from you, and maybe you can share your experience, as maybe we can share what is in our hospital, and we next we can make maybe join research, or maybe we can do the exchange program, something like that. I hope this event is start with very good, and we can continue with another event and another program. Thank you so much. Yeah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Anna, for the opening speech. And then next of our rundown today. Yes, today we have a first lecture from Professor Dr. Salina Husain with the topic Understanding Anatomical Variation and Mucosal Disease of Paranasal Sinuses in Rhinosinusitis. And then we go forward to a panel discussion. And now we have an exciting panel of speakers today, and I hope we can catch many information from this lecturer. Our greeter lecturer, Professor Dr. Salina Husain.
Assalamualaikum and good morning. Yeah. Yeah, first of all, I would like to thank Dr. Anna, Dr. Desi, and the team for inviting me to give a talk here today. Actually, it is an honor to me to come here and share my experience with you all. So, first of all, I would like to say to all consultant and specialist ENT and to all students, there we call postgraduate student. Here we call residents. So you all is like there they call me Ibu. So you all like my sons and my daughters as well. So I know like you this are across like year 1 to year 4, right? So this presentation I try to talk slowly because back home also they said I talk so fast. So if let's say I go too fast, happy to help you because sometimes these paranasal sinuses and all this anatomy is quite difficult and complicated. Yeah. So so the topic that I will talk today is on anatomical variation and its relation to rhinosinusitis. There are so many anatomical variation, but I just talk today is related to rhinosinusitis because sometimes we have to do CT scan if you want to do surgery, right? So CT scan is a must if you want to do surgery because there are other anatomical variations that we need to know. But we give us slowly. We start with rhinosinusitis first. Yeah. Okay. So if I go too fast, please stop me. Yeah, it's not. And because this lecture is about 1.5 hours, so if you feel too long and cannot absorb anymore, I always told my student 45 minutes have to stop. If not, cannot absorb because it's too much knowledge. Your brain have to slow down a little bit. It's normal because study state is 45 minutes and then we stop for a while, 5 minutes. Yeah. Okay, so all right. So first we have to understand what is rhinosinusitis. Yeah. So rhinitis is inflammation of the nose, and sinusitis is inflammation of the paranasal sinuses. So when we combine two, so it becomes rhinosinusitis. So inflammation of the nose and paranasal sinuses. Okay. So this is very common. So about 40% of population has rhinosinusitis with or without underlying allergic rhinitis or non-allergic rhinitis. Yeah. So if the rhinosinusitis is not treated, left untreated, So it has a big impact on quality of life. So many studies done on this about quality of life in rhinosinusitis. So first we have to define what is rhinosinusitis. So I always follow EPOS guideline 2012. So this one is a worldwide use one. So first, patient must have symptoms. So the symptoms must have 2 or more symptoms, and that 2 or more symptoms should be either can be both or can be one of that, nasal blockage or nasal discharge. It can be both, but don't, if patient have one, it's okay. So nasal blockage or nasal discharge, plus minus facial pain or facial pressure, plus minus loss of smell. So history is a must. Yeah. And then and or either or endoscopic signs. So whether patient have nasal polyposis on endoscopic examination, or patient has mucopurulent discharge or edematous mucosa. So if patient have all 3, it's okay, but at least must have one. Yeah. And the last one is CT scan imaging. So CT scan, if there is mucosa thickening, then it will include. If let's say patient has the symptom, yes, the sign, yes, but CT scan, no. But still we can diagnose the patient to have rhinosinusitis. But if patient come to you, like some patient, they like to go to imaging center, kan? They just want to do CT scan, just like that, finish the money. Because a lot of money just spend at the imaging center. Some patients like that. Even in Malaysia, they like to go because sometimes they worry. They don't want to see a doctor because long queue. So they went to a imaging center. So they take a CT scan. But patient get the CT scan because of other reason. When they did a CT scan and the radiologist report sinusitis. And when the rhinologist report sinusitis, they start to be scared. So they come and see you. And then when you see this patient, when you ask the patient has no symptom, and you do endoscopic examination, no signs, but the CT scan has thickening of the mucosa of paranasal sinuses. You cannot diagnose this patient to have rhinosinusitis. That one is very important, because if your indication is wrong to do endoscopic sinus surgery, there is a lot of complication. And we have in Malaysia so many complications post-endoscopic sinus surgery. They have intraorbital, intracranial injury, and then both intraorbital, intracranial, and so many. So it's under litigation. So because I'm one of the expert witness, they call me to the court. So the 2 days before that, I cannot sleep because I have to read all the big or report and all that. So just bear in mind, if there is no indication, don't do endoscopic sinus surgery, because the chance to get complication is very high. Okay, so the rhinosinusitis can be classified into acute rhinosinusitis if less than 12 weeks, or if equal or more than 12 weeks is chronic rhinosinusitis. Yeah. So now we go to the ciliary activity, because we have to understand why this rhinosinusitis happen in variation. Yeah. So first, how the ciliary activity happens in paranasal sinuses. So we know that the nose and paranasal sinuses, we have a cilia. So this cilia, because when we breathe in every day, every second, there's a virus, there's bacteria, and there's a fungus as well, and then debris. So when we breathe in, so the function of mucus blanket to trap all this. So they trap in the nose, and sometimes they go into the paranasal sinuses. So the function of cilia, this one is the cilia. This is the function of cilia. They beat in coordination movement. That means if beat on the left, all beat on the left. Is beat on the right, all beat on the right, because they have to do that to bring all these microorganism up. So if we see in the maxillary sinus here, the ciliary beating start from the inferior portion of the maxillary sinus. So it go up on the lateral and medial wall of the maxillary sinus and push the secretion superiorly into the superior part of the maxillary sinus and finally, it's bring out the secretion or drains through the maxillary ostium. Yeah. So this one is a normal physiology of the mucociliary clearance of the paranasal sinuses. And for the frontal sinus, it starts from the medial part of the frontal sinus, and then it go up superiorly and come down on the lateral wall of the frontal sinus and drain through the frontal ostium. So this is a mechanism that happen every day. And then all this will drain into a space, they call that osteomeatal complex. So when you see this, how it goes, how it works. So if there is any opening, because on the medial wall of the maxillary sinus, they have only one opening, right? Maxillary ostium. If you create a second opening, so it will disturb the mucociliary clearance. So when you create another opening, there will be deficient of the cilia at that region. So the secretion, let's say you make an opening here, right? Or the inferior meatus, right? You make an opening, so the cilia at this region will be deficient. So the secretion, when they try to go up by the cilia down there, then there is no continuation of cilia to go up. So there will be stagnant of secretion at this area. So if this secretion stagnant there all the time, and at one point your immune system is low, then will be infection. So patient will have rhinosinusitis. Yeah? So if let's say if there is or the other one, if you do medial meatal enterostomy, you don't connect the anterior fontanelle and posterior fontanelle together, make a big cavity, there will be a retained secretion as well. So when you do the medial meatal enterostomy, it's compulsory to connect the anterior fontanelle and posterior fontanelle. I will show you later about the anterior fontanelle and posterior fontanelle. Make a big cavity, then basically, when you do the medial meatal enterostomy, you have to make a big cavity, you know. If not, during the healing process, it becomes smaller. So it becomes stenosis. That's why you post-op, after 2 years, you say, oh, got secretion. And the secretion cannot come out because it's stenosis earlier. That's why you have to make a big medial meatal enterostomy by removing the uncinate process, the superior limb and inferior limb. Now, the uncinate process, they have superior limb and inferior limb. So you have to remove both. That's why the opening is big, and then there is no stenosis. Okay, that one is okay. All right. So any question till now? It just ask it's okay, because sometimes just if you just strictly in your mind, I'm not sure this one, I'm not sure, you just ask me, it's okay. Yeah. Okay. So the second one is we have to know the drainage pathway of the paranasal sinuses. So there are two pathways: anterior drainage pathway, which is red in color, and then posterior drainage pathway is blue in color. And this pathway is separated by basal lamella or ground lamella of the middle turbinate. Yeah. So the basal lamella or ground lamella of the middle turbinate here has two functions basically. It has anatomical function and it has physiological function. So anatomical function is separate the cells into the anterior ethmoid and posterior ethmoid. And the functional function is this one. It separate the anterior drainage and posterior drainage. So the anterior drainage is drain the frontal sinus, the secretion from the frontal sinus, and the secretion from the anterior ethmoid sinus, and the secretion from maxillary sinus. So it's drained in the osteomeatal complex and go backward into the nasopharynx. And the posterior drainage is the posterior ethmoid and sphenoid. The posterior ethmoid drain into the superior meatus, okay? And then the sphenoid drain into the sphenoethmoidal recess. And they meet together here behind the posterior part of the middle turbinate to join together and drain into the nasopharynx. So this one is the middle concha, this one is the inferior concha. Okay. All right. This one, there are so many causes of rhinosinusitis. I just give briefly, but we will talk in detail in anatomical variations. Yeah. So the number one is mucociliary abnormality, like in cystic fibrosis or primary ciliary dyskinesia, because the ciliary beating is haywire. That's why they cannot bring the secretion out. Yeah. And then structural abnormality, like in osteoneogenesis, is very rare. But the common one is outflow obstruction, such as in anatomical variations. And then autoimmune diseases like granulomatous disorder, sarcoidosis, Wegener's. And then in vasculitis type of lesion is systemic lupus erythematosus and Church-Strauss syndrome. Church-Strauss syndrome is common in Western country because in Malaysia, I've never met one patient with Church-Strauss syndrome. But in UK, there are so many cases of Church-Strauss syndrome. Yeah, very high. The eosinophy is very high. Okay, and in some patients with primary immunodeficiency syndrome, this one is common in children. They come to you with acute otitis media, going to chronic otitis media, and acute rhinosinusitis going to chronic rhinosinusitis. Then if you give a medication, it doesn't heal. So you have to give some more immunoglobulin. Yeah, so that's what to reduce it. It's common in children. I'm not sure here they have so many cases or not, because there we have a group that treat this type of patient. And then the fifth one is Samster's triad. It's a syndrome of inflammation that involves the asthma, and then rhinosinusitis and nasal polyposis. Yeah, and then imbalance of autonomic supply, like sympathetic and parasympathetic, also can cause rhinosinusitis, but the underlying is non-allergic rhinitis. Yeah, and then in hormonal imbalance, patient with pregnancy, you see, right? When they have pregnancy, they have severe rhinosinusitis. Once they deliver, it's nothing. It just disappear like that. Yeah. And then hypothyroidism as well. Okay. Infectious is due to viral, bacterial, fungal, parasitic, and so on. And we have inflammation like IgE mediated, non-IgE mediated, and some pharmacotherapy as well. For example, is drugs for hypotensive agent. Hypotensive agent drug, and some they can cause rhinitis, like beta blocker and all that. Yeah. So if patient persistent has rhinitis, then we always advise them to talk to medical to change the drugs. Yeah? And then irritants like solvent or this pain thinner and all that can cause rhinitis. Okay, so sometimes there is disruption of the normal ventilation or mucociliary drainage due to surgery or trauma. Surgery is common. Yeah. Okay. Before we proceed with anatomical variation, I want to talk about the osteomeatal complex, because this is a very, very important area in the nose. The most important area is osteomeatal complex, because it is situated anteriorly and it drains so many paranasal sinuses, 3 out of 5. Okay, so first this area that shading is osteomeatal complex. So it is bounded medially by middle turbinate, okay, laterally by lamina papyracea, okay, superiorly by frontal sinus, yeah, and then inferiorly is open into the inferiorly is open into the nasal cavity. Anteriorly is by frontal process of maxilla, yeah, here, this one, I think, yeah, this here. Is frontal process of maxilla here. Yeah. And then posteriorly is by the ground lamella of the middle turbinate. If you see here, so you will know what is the content of the osteomeatal complex. Okay. Number 1 is uncinate process. Okay. Number 2 is infundibulum. Infundibulum is this one, this one. Okay. And number 3 is hiatus semilunaris, this one. Yeah, and then number 4 is moida bulla. Number 5 is the frontal recess, because it's frontal sinus going down is frontal recess. And then number 6 is this area called middle meatus. Okay, so I just want to touch about infundibulum. Infundibulum is a 3D structures. When 3D structures, it has 6 boundaries. Yeah, and hiatus semilunaris is a true 2D structures. If 2D structures, it has 4 boundaries. And if we go one by one, it's like this one, infundibulum. It's very important to know for back home is exam question. Okay, so infundibulum is 3D structure got 6 boundaries. Just imagine infundibulum. So infundibulum. So if you see posteriorly is anterior wall of the bulla. Okay, anteriorly is the uncinate process. Okay, medially is maxillary ostium. Laterally is maxillary ostium. Okay, medially hiatus semilunaris. Because if you are in the infundibulum, you want to go out that side, you have to go through a door. So the hiatus semilunaris is like a door. You open the door, so this one is hiatus semilunaris. Yeah, so medially is hiatus semilunaris. Superiorly is frontal recess. Inferiorly, it opens into the nasal cavity. Okay, cukup tak that boundary 6? Cukup lah. So hiatus semilunaris has 4 boundaries. Okay, so anteriorly is the free edge of uncinate. This one, uncinate process has a free edge. So this one is the free edge of uncinate. Posteriorly is the ethmoidal bulla. Yeah. So medially is the infundibulum. Laterally open into the nasal cavity. Yeah. Okay. Yeah. So this is very important. When after that, I will show one by one the anatomical variation. Yeah. Okay. This one is the that structure in OMC lah. Just the other 6 structures in OMC. Right. So now we go. Before that, I show you the normal middle turbinate and uncinate process. Yeah? Okay. So if you go here, okay, this one is inferior turbinate. So okay. So this one is the I have to go in front a little bit. Okay. So this one is the normal middle turbinate, right? It's straight and it's not enlarged. And this one is on the right. So on the left. Okay. This one is on the left. So middle turbinate. And then this one is the uncinate process. Okay. This one is the uncinate process. And this one is the nasal septum is little bit deviated, but not so much. So you can see that uncinate process here, this uncinate process ni, the attachment is to the frontal process of maxilla. They attach kan? This one uncinate process, they attach to the frontal process of maxilla. How we know that? If you see this this photo, kan? This uncinate process attached to the frontal process of maxilla. So the same. So this one uncinate process attached to the frontal process of maxilla. This one you can see the free edge of uncinate there. Yeah. And then you see this line. Usually when we do the endoscopic examination, we can see this line. This one is maxillary line. This maxillary line is correspond to the frontal process of maxilla, but inside there has a nasolacrimal duct. Yeah, that's why it's like macam elevated like that, because there's a nasolacrimal duct inside. Yeah, so it's a normal. This one is a normal, and you see the uncinate process here. It's like convex. Yeah? It's like convex. You can see like it's convex nicely, because behind this uncinate, this one is free edge of uncinate process. Behind that is infundibulum. That's why they convex. To give a space for the space of infundibulum. Okay, that one is the so now the anatomical variation. First, we see the deviated nasal septum on endoscopy first. Yeah. Okay, when we see here, there's a very bad deviated nasal septum. Then we can see the middle turbinate is pushed laterally, kan? It push laterally. So when we see here, when this one example kan, this one is the nasal septum. So it push the middle turbinate laterally. So because of that, the middle turbinate push the uncinate process laterally. Same, kan? So when this deviated nasal septum push the middle turbinate laterally, so it will push the infundibulum laterally. I mean, the push the uncinate process laterally, so the infundibulum becomes smaller. But sometimes the infundibulum is like obstructed fully. So the drainage from the maxillary sinus, the drainage from the frontal sinus and anterior ethmoid sinus is impaired. That's why rhinosinusitis can occur. Okay, now we go to concha bullosa. Yeah. So this one concha bullosa. Concha bullosa is when the body of the middle turbinate is pneumatized. So there is air inside. That's why the middle turbinate become enlarged. Kan? So when there is a concha bullosa here, it will push the uncinate process laterally. Then we cannot see the uncinate process, right? Because it's occupied by the middle turbinate. So it's like this. If you see on this one, so it's very big middle turbinate. It push uncinate process laterally, so the infundibulum become smaller. Next is paradoxically bent middle turbinate. So it's supposed to be a straight, but this one bend laterally. When this one bend laterally, you can see the uncinate process will be pushed laterally. Same thing. Kan? It's supposed to straight, but it's bent laterally. So it push uncinate process laterally, so infundibulum becomes smaller. Next, laterally bent uncinate process. The same thing. Actually, the laterally bent uncinate process occurs in concha bullosa, in deviated nasal septum, and in paradoxically bent middle turbinate. So it push the uncinate process laterally. So this one is very bad. Deviated nasal septum, right? We can't see anything. So actually they push everything laterally. The next one is perforated uncinate process. All right. Or 180 degree, it turned out. So you can see the perforation of uncinate process. The perforation uncinate process doesn't involve the narrowing of the infundibulum. No. The thing is, when patient have a perforated uncinate process, because all the secretion coming out through the frontal sinus, maxillary sinus, and anterior ethmoid, it go into the infundibulum, right? If there is a perforation, so the secretion will come out through here. So it's not supposed to come out through here. It's supposed to go down there into the nasopharynx. So there will be retain of secretion as well. So some patients, they can have rhinosinusitis. Not all, but some patients, they can have rhinosinusitis because of this. Yeah. So the last one is accessory ostium. Okay, high deviated nasal septum. And they push little bit middle turbinate laterally. So you can see this patient has both perforated uncinate process and accessory ostium there at the back. Yeah? You see the accessory ostium is posteriorly to the free edge of uncinate process. You can see, right? Because the accessory ostium is always posterior to the free edge of uncinate process. Natural ostium is always anterior to the free edge of uncinate process. So if you see here, I just take this from the website. Kan? So we see this one is uncinate process. Okay. So this one is posterior fontanelle. So the accessory ostium is in the posterior fontanelle because it's posterior to the uncinate process. But natural ostium is always in the anterior fontanelle here. So that's why all the time we cannot see the natural osteum. If we don't remove uncinate process, we cannot see the natural osteum because it's anterior to the free edge of uncinate process. So this one is anterior fontanelle, this one is posterior fontanelle. We call this fontanelle because they don't have bone. They have only mucosa. So when we do the medium meatus enterostomy, we have to remove the uncinate process, right? And then we have to connect. If patient has accessory osteum here, we have to take out all that, make a single cavity. So once you remove the uncinate process, remove all the mucosa, connect the natural osteum to accessory osteum, it's become a big cavity. And this uncinate process, it has two limbs. This one is superior limb. Actually, the down one is inferior limb. So you have to remove both. Yeah. Any question? Okay.
Yes, sambil break ya, Prof. Okay, back to the diagnosis, Prof. We oftenly have a consult from our neuro department, our friend, and when they do MRI and they found sinusitis. But after we take history taking and we did some endoscopic examination, we didn't found anything. So what do you think with the patient like that? Is it we still diagnose as sinusitis or not, Prof? Some
I give if
Yes.
like one patient admitted for pituitary surgery.
yes.
So we have to do transsphenoidal surgery with neuro, right? But when they request MRI and they see a thickening of the mucosa on MRI one side, but when we ask the history, when we do endoscopic examination, there is no the what I mean is the thickening to at the periphery.
Yes.
Okay, if the thickening is only at the periphery, but not involve the whole maxillary sinus or not involve even half the maxillary sinus, only at the periphery. If patient has no symptom, no sign, I don't treat. I just proceed with transsphenoidal surgery.
Okay.
Mm.
The most common is patient with stroke, Prof.
A patient with stroke, but patient
Yes.
has no
But,
patient
yes.
has no intracranial complication, right?
No.
Then
But they did MRI and the radiologist said that there is a mucosal thickening in
yeah,
the maxillary sinus or ethmoid sinus.
uh,
So we just passed the patient. We did not treat as a chronic rhinosinusitis.
then we ask the history whether patient has history of all this nasal obstruction or nasal discharge for the past or how many days. We have to ask that. If patient say no, I never have the symptoms, and then we do endoscopic examination all normal, then I don't treat. I just
Okay.
leave it.
Okay, so sometimes it's happen, yeah, Prof. The mucosal thickening in a normal patient.
It's normal.
Yeah.
Let's say study showed, I forgot the paper. If we take, let's say all of you, right? All the students, and I do MRI or CT scan, I think 40% of you will have a mucosa thickening. But you have no symptoms.
Okay, yeah, because we have some patient that the neurologist consult to us, the patient with stroke and the mucosal thickening in the paranasal sinuses.
Yeah.
Okay.
But usually when I review the patient, if there is no response, I just return that no ENT intervention.
Okay, so we have to do history taking and endoscopic examination first.
Endoscopic
Okay.
examination.
Okay, thank you. Yes.
Unless if the thickening is like more
lot,
than 50% or all that, that one is different.
Okay.
It's only the lining that ED matters, but patient has no symptom, then we don't diagnose patient as rhinosinusitis.
Okay.
But the thing is, kena bear in mind, if patient receive like chemotherapy or patient in renal ICU because they have end stage renal failure, right? So if they refer to me, then I be careful because sometimes because they when they give the chemotherapy, the immunity of patient is like suppressed. So the immunity is very bad. So even renal patient in renal ICU, the immunity is very, very low. So they easily for them to get invasive fungal rhinosinusitis. Invasive fungal at the early stage, you don't see anything. You actually when you do a CT scan, you see only mucosal thickening. That's one. For that type of patient, I will do all these sensation tests. So I will test whether the patient lost sensation, because we know that in invasive fungal, the patient will lose the sensation because they involve the neurovascular bundle. So patient, if you poke, however you poke, patient don't have any pain. In that type of patient, I will be very careful if they refer to me.
Okay. Okay. Thank you. Thank you, Prof.
Mm.
Maybe is there any other question? Not yet.
It's okay.
Guys, okay. You can continue, Prof. Thank you.
Okay, so this is a CT scan. This is a CT scan to show you a normal osteomyelitis complex. For this lecture, I just give one card. Actually, I can show you how to read the CT scan on axial, or coronal and sagittal. But I think it takes a long time to read that CT scan. Maybe in different lecture, so I can show you. So you will understand when you see the CT scan, you will understand which part that involve which this one, which part. But for this purpose today, I will show you only the osteomyelitis complex. Why I said this one is osteomyelitis complex. First, you have to see the uncinate process. When you see the uncinate process, then uncinate process that you can see the free edge of uncinate, then you are in the number one, you are in the osteomyelitis complex, or you are at the anterior ethmoid. So how to differentiate whether you see the cut is at the frontal sinus, at the anterior ethmoid, at the posterior ethmoid, or at the sphenoid. So you have it's a lot of things that you have to know about that. So when you see the CT scan in glass, oh, I know this one is posterior ethmoid. And so this one is anterior ethmoid because number one is like free edge of uncinate, and number two, you can see the bulla. And the bulla, you can see nicely the bulla, and you can see the attachment of the middle turbinate to the skull base. So this one is the olfactory fossa, and this one is the cribriform plate. So usually in the anterior ethmoid area, you can see the crystal galli because this one is just enter, so you can't see the crystal galli. At the back there, you can see the crystal galli. The crystal galli is up here. So anterior ethmoid, it will have crystal galli. Yeah. So if you see, and then once the crystal galli disappear, then you are at the posterior ethmoid. So that's how we differentiate anterior ethmoid or posterior ethmoid. And sometimes they all this, you can see the shape of the maxillary sinus is triangular, but in posterior ethmoid is oval. Yeah. And then the eye in the anterior ethmoid is a circle. And but in the posterior ethmoid is triangular. So how we differentiate that. So and then it's middle turbinate. This is the septum. Okay. And this one is lamina preparatia here. And then this one is the hiatus semilunaris, and this one is the infundibulum. Yeah. This one I can see the shadow of infraorbital nerve canal, and this one is optic. This one is superior rectus, inferior rectus, medial rectus, lateral rectus. And then here is superior oblique. And there's a muscle small here is levator palpebrae superiorlis. And if you see some muscle here is inferior oblique. Yeah. That one is the eye. Like sometimes you want to see if you have patient like with acute rhinosinusitis with orbital abscess, kan? So you see whether it's involved or not. Yeah. Okay. So now variation on CT scan. Paradoxically bent middle turbinate. Okay. So we see here this one is normal, right? So they have a paradoxically bent middle turbinate. It's like that. It's supposed to straight, but the body is bent. So when this side is curved like that, it will push the uncinate process laterally. So this one becomes small. This one also becomes small, and this side already got maxillary sinusitis. Yeah, and then this one sometimes it doesn't bend, but the body of middle turbinate too is big. So they push like a boot shape ni. They push laterally, push the uncinate process laterally, so it becomes smaller. Yeah, this one is almost normal. This one is crystal galli. So this one is at the area of anterior ethmoid. Okay, we go to concha bullosa.
I'm
Okay.
sorry, Prof. From
Yeah, here.
if we have patient like this, the right area is still normal in sinus maxillary.
But this one, is it?
Yeah.
Uh-uh.
When we do the operate, should we do the two side or only the left side?
Okay. If this one, I think if we see in endoscopic view, there will be, totally blocked. You cannot see, right? So usually on this side, I will do middle conchotomy.
Oh.
I will reduce this one, because if you don't reduce this one, it might recur or difficult for you to do MMA.
Yeah.
Because it's blocked, difficult. It's difficult for you to do MMA, so I have to reduce this one. They call that
Okay.
middle conchotomy or middle turbinate resection.
Okay.
Yeah, and then remove the uncinate process and open up.
Yes, but should we do the same thing in the right side?
The right side, no,
Yeah.
because
No.
it's normal.
Oh, okay. Also, there's a paradoxical turbinate
But
there.
paradoxical bend, maybe this one is worsen. This side is better
Oh,
because the
okay.
space is more on this side compared to this side. There is space.
Okay.
We see on CT scan, right? We see like it's a little bit a difference, but when you see endoscopically, it's a big difference.
Oh,
So usually, if this side is normal, I won't do.
okay.
If patient has maxillary sinusitis on this side, then I will do, because it's difficult. Like if let's say we do on this side, if let's say because it's near, it push and then it's near to the orbit, and then we want to open up the uncinate, suddenly we penetrate the orbit. Okay, we penetrate the orbit and the patient has a medial rectus injury, and if we go to the court, we will lose, because there's no indication to do surgery. Yeah. So they because their lawyer, they just find a way to get money. So they will use that reason. So that's why I usually don't touch them, because I will lose 5 million, something like that. So I don't know, but in Malaysia it's quite difficult. So if like this kind, usually I won't touch. I will touch on this side only.
How about if we did endoscopic and we found there is a mucosal and the just like mucoid discharge in the right side, Prof.
Okay. If there is a mucoid discharge,
Yes.
and there is no mucopurulent discharge,
Yes.
and the mucosa thickening depends. If the mucosa thickening is like, you can see that it's blocked the osteomeatal complex, then I will do. But the thing is, on CT scan is normal.
Okay.
If on CT scan is normal, it's very dangerous, because lawyer, they will see this.
Oh, okay. Yeah. So the CT scan is the gold standard.
The gold standard, because you have to take a CT scan before we do surgery, right? So
Yeah.
they will confront you based on CT scan.
Okay. Okay. Thank you, Prof.
Okay. So okay. This one is concha bullosa. Same thing, Concha bullosa is very big, push laterally. Like this one is normal, right? So it just go nicely down because it's normal. Well, it looks bigger, but at least it doesn't cause the narrowing of the infundibulum. This one big, and then it cause the infundibulum to it's like this one is if you see on endoscopic examination, it's like it's convex, it's like that. Let's see. But for this one on the right, it's become concave. It's turned. Kan? It's supposed to convex, it's become concave. If you see here, it's like concave. Concave laterally. It's the C too is like that. But normal supposed to like that. It's like reverse. And this patient also has this one, deviated nasal septum. And this one is still at the anterior ethmoid. There you can see this one, anterior ethmoid artery coming out. But the anterior ethmoid artery is in the skull base. So if you do surgery, it's quite safe lah, because in the skull base. This one is where when you see the beaking, it's a V shape. at the skull base, and the lamina papyracea is where the anterior ethmoidal artery exit. Yeah, it's through the anterior ethmoidal canal. So here is here. But if you see another cut, you can see nicely maybe. Okay, we go to pneumatized. Okay, so this one is pneumatized lamella of the middle turbinate. Okay, middle turbinate have three parts, right? The middle turbinate. One is the vertical one, attached to the skull base, and attached to the anterior skull base. And they have a second one, is turn, become the ground lamella or basal lamella, and is attached to the lamina papyracea. And another one is a horizontal. It go posteriorly and attached to the perpendicular plate of ethmoid. Perpendicular plate of palatine bone. So there are three parts, kan? But the anterior of the first part of middle turbinate has three parts as well. Kan? Has three parts as well. This one is body of the middle turbinate. This one is lamella of the middle turbinate, and it's a neck of the middle turbinate. So the neck of middle turbinate is actually the medial boundaries of the frontal recess. That's why it's divided into three as well. So this one is pneumatized lamella of the middle turbinate. So sometimes if the pneumatization is bigger, it will push the ethmoid sinus laterally. So the ethmoid sinus becomes smaller. Yeah. So when you do endoscopic sinus surgery, then there is a high chance to break the lamina papyracea because they become thin, kan? It's so near, then you put the ball probe or anything, they just direct go to the lamina papyracea. That is dangerous. That's why CT scan is a must before you do endoscopic sinus surgery. Okay, pneumatized uncinate process. Okay, nah? This one is laterally placed uncinate process. Okay. So laterally placed uncinate process. So this one is because of paradoxically bent middle turbinate, right? So it push the uncinate process laterally. If you compare here, is big space, but here is already near to the lamina papyracea. This one is dangerous because sometimes you put backbiting at the free edge of uncinate and go direct to the lamina papyracea. It's dangerous. So have to be careful when you do surgery. Okay, now we go to, Okay, pneumatized uncinate process, this one. Okay, this one pneumatized, this one uncinate process, pneumatized. So when there is a pneumatized uncinate process, the infundibulum automatically becomes smaller. Okay? Because it's uncinate process is small, but there is a air inside, then it block the infundibulum both sides. Okay, agonesi. Okay, so this one is enlarged agonesi. Agonesi is the anterior most cell of ethmoid air cell. So when it's enlarged, they block everything. So when it's enlarged, the infundibulum block, the frontal recess becomes smaller. So it's block everything. It's like this, patient can have frontal sinusitis because they block from superior. They block the frontal recess. So the frontal sinus cannot drain, then patient can have frontal sinusitis. Okay, this one is rudimentary ethmoidal. Okay, so this one is concabulosa. You compare the ethmoidal on this side and ethmoidal on this side. This one looks compressed, kan? They call that rudimentary ethmoidal because it's become smaller. This one is dangerous to do surgery because it just plaster to the lamina papyracea. Haller cell is this one. Haller cell is common. So this one's haller cell is like infundibulum. When you open up the infundibulum, remove the uncinate process, you can see the infundibulum. When you open up, you tend to open up into the haller cell. Because it's near. Remove the uncinate process, go to the infundibulum, then you see is haller cell. So some people, they mistake. So they thought that because a lot of bleeding and everything, so they thought that, I dah open the maxillary sinus. Actually, it's not. The maxillary sinus is down here. Down here is maxillary sinus. This one is haller cell. So if, let's say, they mistaken haller cell and maxillary sinus, patients come to you with recurrent rhinosinusitis. It's not settled. Yeah? That's why we have to see the CT scan. Here we got IGS, image guidance system. You know, if it's like if your hospital have that luxury, can just see and then you cannot miss lah. Yeah, you cannot miss the cellular cell. I also don't use for ENT. I use that with surgery, with neurosurgery only. Okay. This one is Kuhn cell. Everybody's know, Kuhn cell type 1, type 2, type 3. So Kuhn cell, many patient, many a population, they have Kuhn cell, but not all can cause frontal sinusitis. It depends. Sometimes I don't know, they have allergic rhinitis more, and then they can have that rhinosinusitis. Yeah, Kuhn cell type 1, 2, and 3. And the other one is hypo. This one last one. The hypoplastic maxillary sinus. This one is maxillary sinus on this side and maxillary sinus on the left. Okay? The maxillary sinus is smaller. When maxillary sinus is smaller, it's dangerous because the eye become lower. Okay? When you open up the uncinate process, memang its tendency to get into the orbit is very, very high, and that is near the media rectus. It's happened in Malaysia. They open up, and then a lot of bleeding, and then actually they injured the media rectus already. So patient have diplopia. Diplopia usually can, if complication occur, don't fight with patient. You will lose one. So you have to talk to your lawyer. The lawyer will settle outside of the court. So it's better if you like adamantly, or it's not my fault, then you have to pay a lot. So usually in Malaysia, we just settle out of court. Okay, now we go to acute rhinosinusitis. Or you want to stop first?
Okay. Sampai jam berapa? Oh, okay. Is there any question maybe for the resident for the anatomical physician or maybe for the specialist? Maybe sharing experience about the anatomical variation. Actually, we never see the perforated uncinate process, Prof, or the what is that? Pneumatized uncinate process. We never see in our hospital. Okay. But osteum aureus is commonly we found it in here. Yes, they always we can see in the back or behind the free edge of the uncinate process. And sometimes for the resident, they just say, "Wow, we found the maxillary osteum." I just said, "No, no, 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 it is not the osteum because if we don't use the 30 degrees, sometimes we cannot find the osteum, naturally osteum actually." Yes. Okay. Just any question from you, Doctor?
I'm sorry, Prof. I want to ask about the anatomical. When you say uncinate process with concave or convex form, is it same like deflexy to the lateral and deflexy medial, or oh okay, oh so deflexy medial is same like convex ya, cebung. Oh ya, okay.
Okay. Thank you, Prof.
Prof, I wanna share my case in here. I'm in allergic division. You mentioned before you rare found a case with Church-Strauss syndrome. I have a case consult from the internist she already diagnosed with Church-Strauss syndrome and uh, want to know about ENT evaluation. And in my patient, I found allergic rhinitis with the positive skin prick test, and also she has an ear problem with the uh, B in tympanometry, type B, type B tympanometry. Uh, uh, the Church-Strauss syndrome is internist patient. We also lack of experience with this patient. I'm curious about your experience with the patient like that, especially with a patient with immunological disease.
When I did my fellowship in UK, they have all these cases, church straw syndrome. Actually, when patient come to you, they have nasal polyposis. But when you treat, it doesn't regress. So there's something wrong. And so they take the IgE, all this blood IgE and all that. And they also do vitamin D deficiency. They check for vitamin D. If patient have vitamin D deficiency, they will give vitamin D supplement. And also they will check for immunoglobulin as well. Because all this is like more to immunology part, right? So they have to do batteries of tests lah, belongs to allergy, belongs to allergy and immunology. There's a lot of tests, right? Under immunology, there's a batteries of tests. So they will rule out one. Oh no, vitamin D no, IgE no. After that they make a diagnosis. Yeah, that's like
Okay, because because I have the case, I read some journal that mentioned that early diagnosis of Church-Strauss syndrome, it's had a ENT problem. So in the future, maybe all the patient with immunological disease may have to consult to the ENT, because we can prevent the complication of the disease.
allergy in Malaysia. Allergy is under rhinology. We have a rhinology, and under rhinology we have 5 such super subspecialty. So we have allergy immunology, we have endoscopic sinus surgery, skull base, smell and taste, and the other one is facioplastic, is open septorhinoplasty and all that. So the one that in charge down here, in charge the allergy immunology, they work closely with immunology people, microbiology. There we have a clinical microbiology. They will do all the tests. Yeah, and then we have a society, a Malaysian Allergy and Immunology Society. So we have circle of friends. How if like we have a problem with the cases, and then they will refer to immunology, because I don't involve a lot in immunology part.
Thank you.
All right. So now we go to I add I just add because to talk some more, so I can reach 1.5 hours. Okay, so okay. Or you or any or you want to do case discussion?
Yes, maybe we have a case that we can discuss is about the anatomical problem with the patient. Yeah, can we? Yeah, Dr. Norma, can you? Yeah. So Prof can take a break. You can sit down here, Prof, and we have a discussion. Yeah. Is the case for the patient with the anatomical variation? Because we have a very interesting case, her case actually.
Because they want to present.
Oh, yeah. Okay. That's okay. They will change. Yeah. Nanti dibantu dioperatorin. Oke.
Good morning, Prof. and Doctor. First, let me share you with our case in here from case 1. Female, 22 years old, with onset of symptom in 6 months. The patient complains about nasal discharge, fast 5 in left and right side, and nasal blockage, fast 4 in left and right side. And the patient also complain in facial pain. And the medical history, patient has asthma and allergy with SPT positive, and the past medication is patient using fluticasone forward. And from the endoscopy, we found hypertrophy nasal turbinate in left and right side, and the mucoid discharge. And the laboratory finding in this patient is anemia, microcytic hypochromic, and the eosinophilia from blood count is 9%. And then from CT scan, paranasal sinus CT scan from coronal section, there from this, there are bilateral ethmoiditis and bilateral maxillary sinusitis, and there are obstruction of osteomeatal complex, and there are nasal deviation in here, and hypertrophy turbinate in right and left side. Pardon me, Prof. We just have coronal and axial section. From the sagittal is there are no from the axial section. There are bilateral maxillary sinusitis, bilateral ethmoiditis, and obstruction of osteomeatal complex, and then caudal nasal deviation and hypertrophy turbinate.
But the first case, Prof. I think in this coronal section we can find there is a isodilation, not much, but slightly isodilation in the left frontal sinus, and then we can see that it's a nasal septal deviation to the left, and we can found that there is a obstruction in the complex osteomeatal. And also we found the isodilation in the both side of the maxillary sinus and both side ethmoid sinus, but that's not a full isodilation. It's just partly. So what do you think about this patient, Prof?
Can you show me the symptoms? Okay, so if me like this endoscopic findings, there's no mucopus, no polyps, right?
No polyp, but there is we can see that the endoscopic is very edema and with the some mucopurulent nasal discharge, but mostly mucoid nasal discharge, yeah, Prof. We can see, and the septal body in this side, the nasal septal deviation is post the middle turbinate to the left side.
Okay. Okay. For this patient, if let's say this patient comes
Yes.
to me for the first time, so female, 22 years old, so has history of 6 months, kan? 6 months nasal discharge, nasal blockage, and facial pain. So because the vast visual analog scale is 5, so it's affect the quality of life. The one that most affect quality of life is facial pain because it's 6, right?
Yes.
And then this patient has allergy and asthma and SPT positive. It's like chronic rhinosinusitis with underlying allergic rhinitis, right? And then this patient was given fluticasone furoate for if this patient come first to me, I will give if let's say no mucopus discharge, so I will give the medical treatment. That means I will complete the medical treatment, corticosteroid nasal spray one, and then antihistamine because patient have allergy. And then because patient have allergy as well, so I will cover with steroid as well, but very low dose steroid. And then usually the first one I won't do the laboratory findings, but maybe it's different. It's okay. But I will see the patient in 2 or 3 months time. So once let's say the patient comes to me with this visual analog scale, and after 3 months, I will see whether the visual analog scale is reducing or increasing.
Okay.
Then, if let's say reducing, if patient okay, and I
That's
just
okay.
continue medication. If the visual analog scale is worsening, and then I will take CT scan. Then the CT scan again. So I'll
Yes.
take the CT scan, and then the symptom is worsening. The CT scan the CT scan, the CT scan is this one. So if worsening after 3 months, then I will do endoscopic sinus surgery.
Okay.
Mm.
So this patient is referred to our hospital because it's already treatment in
Outside.
yes, the
Mm.
outside. And the treatment is with the antihistamine and also the nasal steroid prop. So yes, we did the CT scan because there is no improvement in the there is no improvement for the treatment.
Because facial pain, one side or both side?
Both side.
Both side.
Both
It's,
side.
it's like here, it's like in front, frontal headache.
The
From-
maxillary.
From maxillary.
I think the facial pain because of this Prof.
Facial pain, of course, I can see here, this one.
Which one? This one, Prof.
Where the other pen?
Yeah.
I need to
Okay.
pen, this one.
Yes. From
From
the endoscopic. Yeah.
Deviation.
Right, that's it. So,
Septal body and
The hypertrophic of the septal. So the mucosa of the septum is very
yes,
Yes.
okay. It's straight, right? Yes.
it's not straight.
Yeah. Because if let's say this one is turn very bad as well, and that's the middle of the minute, and what's the muradia?
Yes.
Right, it's like headache. So that one, can.
Yes.
Right?
Yes.
Like this thing.
Yes, from the endoscopic, we also see that there is a edema and the contact from the this one, Prof.
The complex all block, right?
Yes, I think that's the cause of the facial pain. Yeah.
This one for bubble. This one.
Yeah,
I think that's maxillary sinusitis.
maxillary sinusitis. Yes.
That's compulsory to open up.
Yes.
After you give the treatment, antibiotic, everything is not settled, then we
have to open. Yes.
Prof, I want to ask about the steroid low dose medication. For how long we can use the steroid and how milligram? And
like a weekend. So I will start with antibiotics first. I will start with antibiotics. The antibiotics that I will start is because we have antibiotic guidelines. The first one, what we want to give. The second one, the third one. Usually the first one is given by outside.
Yes.
Can because they if they give augmentin, it's not original. So when they come to my side, I will give augmentin first. If they already give augmentin, I will give Zinat, the third generation cephalosporin, or the last one is Avelox. If let's say the three medication it doesn't resolve, weekly I will give. Doesn't resolve, then I will do surgery.
You mentioned about the low dose steroid.
For the steroid, if there is no infection.
Okay.
Uh.
What kind and how long?
Okay.
Dr. Nurma asking.
Okay, the low dose steroid only for chronic rhinosinusitis is not acute. Acute rhinosinusitis usually I won't give, but for chronic rhinosinusitis I give a low dose steroid 50 milligram daily for 2 weeks. Low dose steroid is a prednisolone. It's oral prednisolone. Actually the range is between 15 to 25. Tapi I just choose 15. And then you can go up to 25 if you see the patient body weight is more than 50 or more than 70, like that, you can increase the dose. Maximum is 25 daily for 2 weeks.
Thank you, Prof.
Thank you, Prof.
Okay.
And
The second case, maybe we can move to the
the second
second.
case or the surgery?
Oh yeah,
The surgery or
do you want to see what we found during surgery? Yes, okay. Yes, this is paradox. Yes. Yes. The paradoxical events is always there is a polyp, Prof.
Yeah, retention polyp there.
Yes,
On that
retention
side is
polyp.
retention polyp. Yeah. On this side,
Maybe because of the paradoxical event.
Caliban middle to be
Okay.
yeah.
And the left
This one,
side,
yeah,
this
this one, the one that got.
yes,
This one.
this one is the one that got contact headache.
Is there any pus inside?
I forgot, Prof. This not my patient actually. I think not. This is Dr. Desi. No?
I think maybe got pus or.
Is there any pus inside?
just polypoid?
Polyp, huh?
Yes. I think it's yes, it's only polyp, Prof.
Polyp in
Because
maxillary.
already receive antibiotics.
Yes.
So the pus, but it's actually you can open up because it's not resolved with antibiotic first and second time, kan?
Yeah.
It's okay to do surgery.
Okay. We always do this medialization for the middle turbinate, Prof. To open the yes, middle metal.
Medial metal. So if not, it become lateralized and
Yes.
everything.
Yes.
Me, I do Bogerization.
Oh, okay.
Do the scoring on the septum.
Yes.
And then do scoring on the middle turbinate.
Mm.
Using curette. Curette, or I do scoring with some
You make scar and then
usually curette is easy.
oh.
Just scratch.
Uh-huh.
Just scratch the middle turbinate, and I mean just scratch the medial part of the middle turbinate, and then scratch the septum, and then put the packing. Push everything and put the pack in the
middle metal.
In the middle meatus.
How long the pack?
The packing too not too long. Maybe around 3 days saja. Or 2 days.
Okay.
And there's some packing is absorbable. So it just
release.
disappear by itself. So
Okay.
it takes about 7 days lah.
Because in the when we didn't do the medialization, so they become collateralized and they obstruct again.
I understand.
Okay.
How you do that suture though inside? You use a needle 13 mm, the smaller needle.
Yes,
is it?
yes.
The 13
Yes.
mm needle, the straight needle, right?
Yeah. No, the curved
The
one.
curved needle.
The curved one.
Because we have a 13.
Oh, Oh, no.
We use that as well before, like we use that suture.
Oh,
Through and through.
we
Oh,
just
inside.
use the
The curve.
curve one.
Oh.
Yes.
But it's quite difficult to go in. But
No,
maybe
it's
because you get used then easy.
yes.
Because it's curve, can. Because it's
Can.
curve.
They can all. We try to minimalize the complication after surgery because the lateralize of the middle turbinate. I think this is the easiest part that we can do. Okay, the next
The
case
next
maybe.
case 2.
I thought I bring the straight needle.
Okay. Sorry. I will ask you where is the sleep needle? And then they not produce here.
From case 2, this is a female, 53 years old, with onset of symptom is 2 years, with patient just have a complaint about nasal discharge with fast 5 in both side, and patient have diabetic in 7 years, uncontrolled with insulin dependent, and the allergy with SPT positive, and the past medication is just fluticasone furoate, and from the endoscopy, we just found the edema and polyp with nasal discharge. Yeah. And the laboratory finding is eosinophilia with 16% and hyperglycemia. And in this patient from the CT scan, we found that the maxillary frontal and sphenoid is hypoplastic. Doesn't have
Yes,
Smaller.
the ethmoid and maxillary is hypoplastic. Yes, this is Dr. Desi patient. So this is the what Professor Salina said before. Yeah, the eyes is going lower down because the maxillary sinus is hypoplastic. So we have to be careful, yeah, Prof, to open the yes.
So I think this patient is black ras apa namanya itu? Kalau negro tuh apa? Negro from Papua, from Papua, east of
Papua.
Indonesia. So the nose, anterior nose is bigger here. Like the CT scan for children. Ada foto wajahnya? Foto wajah ada nggak? Nggak ada.
Oh, yeah, you're like, bukan perempuan dulu, the orang Indonesia, the ability to go. Yeah.
So when I do and rain and nasal discharge, Prof.
Actually,
Actually,
nasal obstruction and nasal discharge.
yes.
and then you treat
The
that
most
with
complaint is nasal discharge.
the nasal discharge, push nasal drip or nasal discharge anterior.
Yeah, nasal drip also.
Yeah,
as
push
well.
nasal drip.
Yeah.
So treated with corticosteroid therapy, all this done already.
Done.
Done, but
Because
the
it's
symptom
from
persist.
Papua, yes. So the doctor in Papua already give her steroid and nasal saline, and yeah.
I think this patient might have a ciliary impairment as well. That I'm worried is when we do surgery, right? When you do surgery, the postnasal drip persists. The postnasal drip tu persists because the problem is the ciliary function. I'm worried that, but actually, if let's say patient has no other medical problem, and then only this, I think it's okay to do surgery, just open up. But if like post-op, patients still have post-nasal drip, then you have to do all this workout, immunology workout.
Yeah, actually, when I do the maxillary, I only doing uncinectomy, and maxillary is really small. And but when I do the ethmoidectomy, there's a lot of mucoitis from ethmoidectomy in the cellulae. In the cellulae, we found discharge. Polyp ada ya, kalau nggak salah ya. Yes. Yeah. This is uncinate, Prof. Yeah. Yeah, middle turbinate is the polypoid. Yeah. Okay. The middle turbinate is polypoid, and then when I go to the ethmoid anterior and posterior, yeah, yes, the mucous is polypoid as well. Yeah.
If patient have nasal polyposis like this, will you give a steroid pre-op?
Yes.
How long? 2 weeks or 1 week?
Hampir 2 bulan.
1 week.
Almost 1 month.
The steroid.
The oral steroid.
The oral 2 months.
Oh, oral.
No, 2 weeks.
Nasal steroid about 1 month.
No, the nasal steroid, yes, you will give continuously, like the nasal steroid. But how about the oral? Oh, like me, if patient have nasal polyposis, I will give oral corticosteroid therapy 1 week before op, together with antibiotic, because I want to reduce the bleeding and reduce the inflammation. And
1
post
week,
op,
yeah.
I will continue with oral steroid another 2 weeks. Because if you give pre-op, you have to give post-op. If not, there will be surge of IgE, and then the polyp post-op will be more. That's why I cover pre and post.
With antibiotic as well.
Antibiotic as well.
Oh, okay.
Augmentin. Yeah.
Augmentin. We give intravenous steroid about 2 days. 2 days before. Yeah. But
we give 1 day before surgery and 3 days after surgery. Or after that, it depends. Usually it depends what we found in the clinical examination. So we always do the examination in the first, second, and fourth week after surgery. And we found the polyp actually we usually found polyp in the second weeks after surgery. So we give the oral steroid, and sometimes we give the nasal dosing with the steroid also. Yeah. Usually in the fourth week, the polyp will be reduced. Yes. Yes, the judging with steroid.
What type of steroid do you give?
Budesonide.
Budesonide in vial or
Yes, in vial. In vial, we mix with the nasal dosing.
But it's quite expensive, right?
Yeah, that's why we only one vial and we mix with the 5 millimeters, 5
500.
liters, 500 milliliters, and we ask patient to do nasal dosing 2 or 3 times a day.
Okay.
So it's will last for 2 weeks.
Yeah. Okay.
But sometimes we give the high dose shot therapy for the steroid, Prof. So for 10 days, we give the high dose shot therapy and we use metoprenisoron 64 milligrams.
Oh, it's in vial as well.
No, oral.
Oh.
But we tapering off.
Oh,
Yes.
hydrocortisone.
Methylprednisolone. Yes.
Tapering down.
Yes, tapering down. Because we now there is a restriction in antibiotic, Prof. So we don't give antibiotic before or after surgery unless we found there is a purulent discharge. Yes. If not, we not give. Yeah. Yes.
Most of a surgeon in the world, they don't give antibiotics.
Yes.
They don't give. I just because I follow because my senior give kan. So I did a study. There are two groups of study and two group of people. So one group given steroid and antibiotic or a steroid antibiotic. One group given or a steroid only. One group we didn't give anything. Actually, there's a significant difference. But the thing is, anywhere in the world they cannot follow because there's restriction of antibiotics.
Yes.
Kan? But in Malaysia, it's still okay. I can give now.
Yes. Okay. Thank you, Prof. Maybe we can break for the coffee break for 15 minutes. After that, we can continue the lecture. Okay. Thank you, Dr. Norma, for
Thank you,
presentation.
Dr.